Hello everyone, Assalamu alaikum, namaste, sat sri akal and adab. Welcome to this event. I am Dr. Sara Ali. I'm a diabetes consultant at Royal Free Hospital in London, and I am also a trustee for the South Asian Health Foundation. It gives me immense pleasure today to have with me my esteemed panelist, who I shall introduce you to in a few moments. And we're going to be discussing the experience of South Asians during the COVID-19 pandemic. And we hope that we'll be not just only focusing on the clinical aspects, so the patient perspective, but also covering a little bit about research, but also what it was like to be a frontline worker in the NHS and being South Asian. But firstly, I just want to thank Benita Kane and the other founders and organizations of the South Asian Heritage Month for giving us this platform to tell our narratives, because our stories do matter. And also to the South Asian Health Foundation for supporting this event. So I'm now going to move over, and because you've heard enough about me, enough from me, so I'm going to move over to our amazing panelists, and I'm going to start off by introducing each, and they're all going to give a little bit of an introduction and their perspective. And I would like people in the audience to, if they have any comments or questions, drop them into the comment box, because hopefully we should be able to have a panel discussion and answer any questions. So here we go. I'm going to first introduce Professor Kamlesh Khunti. I don't think he needs any introduction, but he's a professor of diabetes and vascular medicine. He's a GP researcher at the University of Leicester, and he also leads the ethnicity subgroup for the Scientific Advisory Group for Emergencies, so SAHF, and he has an extensive understanding and research in how the pandemic has affected South Asians and health inequalities. So over to you, Kamlesh.
Thanks very much, Sarah. Are we just doing introductions initially, are we?
Yes, and a little bit of perspective from your point.
Well, in terms of perspective, I think the pandemic hit us in January of 2020, and it's just declared level 4 national incident on January 30th. And we started having guidance in February. Minimum operating standards started in February. And daily reporting by NHS Trust started in March. In March 23rd, national lockdown measures came into effect. Pandemic, as you know, hit Spain, Italy, China before anyone else. And until that time, we hadn't heard anything about the COVID pandemic disproportionately affecting the ethnic minority communities. And that's when Wasim, who everyone knows here, sent me a text, and we started discussing this. And a number of people started sending texts saying, we're seeing more people from Black and South Asian backgrounds come into intensive care unit with COVID, and it's affecting younger populations. So I put a tweet out on the 1st of April, and I think that's the first time someone had raised the question, is it affecting ethnic minorities more? And I was bombarded with trolls saying I was scaremongering. But fortunately, within a week, the ICNARC data came out, and that showed that although the UK population, about 14% are of ethnic minority backgrounds in intensive care unit, within April, they were seeing 35% who were of non-white origin. So that was the first signal. And then since then, there's been a plethora of studies that have come out, all of them showing that South Asians and Black communities have been affected the most, mainly people living in more deprived areas. And it's about a twofold higher risk in South Asians. And then it varies from 40% to 100% increase, depending which studies and what they have adjusted for. So we started getting a lot more reports, and I think that's when the government suddenly started doing something. And April 17th is when the CMO, working with the PHE, mentioned that we need to have better understanding issues, and it was highlighted in the Parliament by Robert Jenrick on April the 17th. And then April 19th, the risk assessment came into force, and I was fortunate enough to be asked by NHS England to lead a risk assessment framework, which has been on the whole been positive, but you still hear pockets of people in certain NHS regions that are saying they still haven't had the risk assessment done. And then in May, support measures for ethnic minorities came through, and the SAGE and Atia was a key part of that. SAGE ethnic subgroup came out with a number of reports about multi-generational households, about vaccinations, and we and others have been working through that. June, NHS also set out actions to protect ethnic pregnant minority women, because we know that the first report that came out showed that 55% of pregnant women admitted to hospital with COVID were ethnic minorities. Since then, the work has continued. PHE report came out in June, again showing that elderly men and those living in most deprived areas were affected the most. Then working with the ONS, we got out reports saying it's the multi-generation households and ethnic minorities living in deprived communities. Then the second wave came through, and then within the second wave, we were seeing slight differences. So in terms of the Black ethnic minority groups, there wasn't a difference with the white populations, but there was still with the South Asian populations, even more so now in the Pakistani and the Bangladeshi groups. And again, most of this was modeling studies showing this is likely to be because of multi-generational households and also the workforce in terms of the outpacing roles that these populations had. Leicester, as you know, has been in lockdown, and then we had quite severe outcomes we were hearing about in Blackburn and Oldham, and restrictions were tightened in these areas. PHE report in June came out with a number of recommendations about mandatory ethnic data collection, community participatory research, improving health access, experience and outcomes, accelerating cultural tailored chronic disease efforts. And again, Atia has been quite instrumental in helping out with these areas. Then the translation services came through, the language translation services, all COVID testing sites should be there. This came out in June. And then July, the research interest increased, and UKRI and IHR awarded about £4.3 million to 6 new projects. And then there was a July, the people plan, and then September, there was more data on protective equipment. And then there's been, this year, there's been a lot more about community champions, and about £23 million came to 60 local authorities, mainly in deprived areas and in areas that had a high proportion of ethnic minority populations. February, JCVI came with published statements encouraging active promotion of vaccine uptake in high ethnic minority groups. STPs were given additional funding. There were guidance on supporting vaccine uptake during Ramadan in April, and the government's Equality Office, alongside the newly formed Race Disparity Units and Equalities Minister Kemi Bandi, are working continuously to address these recommendations. If you tell me, have we done enough? We will all say we haven't done enough, but things have moved on, and they are gathering momentum. We're seeing now, in terms of the level of infections are going down. We still need more data. There's quite a lot more activity still going on. For example, is there a delay between symptom onset and admissions? And that work we're doing with ONS at the moment. Harpreet will talk about some other work that's going on, looking at what interventions have worked, because we want to prepare for the next pandemic now. We know ethnic minorities have been affected disproportionately, and there may be other pandemics, and we want to get ready for them. So there's work that's Harpreet and a number of other people are leading on to say, what are the interventions locally that have worked? I think I'll stop there now, just to give you a chronological experience of what's happened in terms of the South Asian communities. Thank you very much.
Thank you, Kamlesh. That was a great introduction because that's really set the scene for us, and you've raised a lot of topics that I think we'll definitely come back to. So thank you very much for that. So I'm now going to move on to Dr. Atiya Kamal, who's a senior lecturer and health psychologist at Birmingham City University, and she's been involved in research and policy in relation to ethnic health inequalities during the pandemic. Over to you, Atiya. Thank you.
Thank you, Sarah, and thank you, Kamlesh, for setting the scene. And it's been we've worked closely on those reports, as you say. So what I wanted to do is share my reflections on community engagement with South Asian communities during the pandemic and the lessons learned. So, if I think back to what communities were saying towards this, in the earlier stages of the pandemic. They were talking about, well, actually, let me tell you what that community engagement involves, sorry. So a lot of it has been interview-based, qualitative interviews, working with communities themselves across a number of different aspects of the pandemic. So this includes public health communications, how communities are managing risk, how our South Asian communities are implementing the guidelines in different settings, such as the household, and then also their experiences of vaccination. And this is with the South Asian population in general, so at a community level, but also with community champions and public health teams across the UK. And so in terms of what my reflections were, what I saw was there's been a recurring theme that comes up. Whether or not I ask the question, and regardless of what the topic is that's being addressed, the issue of trust comes up time and time again. And so what my experiences show is that trust is complex, it takes time to build, and mistrust cannot be resolved overnight. So in the earlier stages of the pandemic, what we found was that mistrust was in relation to central government communications and the role of mainstream media. So what, some of the things that people were talking about were, the media has spent years demonizing our community, and then suddenly we're expected to believe what they say. So we could see that the challenges that presented when we were in this period of uncertainty, and in terms of where that messaging came from. So, of course, it highlighted the importance of having those trusted voices from within the community. But what the challenges that came up at that point were that it's not enough just to have somebody who looks the same, if you will. And some of the trusted sources or respected leaders maybe weren't the most respected sources or trusted voices for all segments of the South Asian community. And so it's highlighted that, public health teams, formal organisations and community leaders, we need to move beyond just a tick box exercise of liaising with people from within the community, and actually it needs to be authentic. We need authentic representation, trusted sources that lots of different people can relate to from within the community. And so faith leaders are very important, community leaders are very, very important, but we also need to ensure that they are reaching young people, for example, and women. And so it highlighted the complexity of how we build trust. And I think one of the most important take-home messages here is that trust isn't just a thing that exists between members of communities and their leaders. It's a relationship that takes time, it's built on authenticity, and it's about understanding the needs of communities and their concerns. And that really came through in our community champions team. And so I guess, at this point in the pandemic, I think we have learned a lot about how to engage with communities, who we need to engage with, but also the need to work with formal authorities in terms of long-term investment and long-term support to not only build but retain trust over time. Thank you.
Thank you, Atiya. That's great. And we'll hopefully come back to that because it would be really interesting to know a bit more about those authentic voices and the community champions. So now I'm going to introduce Dr. Harpreet Sood, who's a GP in London. He's also a clinical advisor for COVID vaccine program and is a board member for Health Education England. Some of you might know him also from yesterday. So over to you, Harpreet.
Thank you, Sarah, and good evening all. Thank you for dialing in, and great to be here amongst other colleagues. So I'm just going to give a personal reflection on what made me firstly get involved with more of the vaccine program, and then secondly just talk about some of the things we are doing at NHS England as part of the COVID-19 vaccine program. So for me, really, back in December, I was talking to my parents, and they received a number of WhatsApp messages saying that there's a lot of information going around about vaccines, and we're not quite sure we want to get the vaccine because of all the things that people are talking about. And I felt that if them who have two GPs at home, both myself and my brother, who were giving them this advice, there are probably many other people that don't have access to GPs or doctors that easily, and were probably making decisions based on these messages that they were getting through WhatsApp. And there was a lot of misinformation flying around, and I felt that there was something that really needed to be done. And like Kamlesh said, and Atiya's also outlined, that the importance of misinformation and trust in the communities was very high, and it still remains high. We still see, where I'm seeing in my practice in particular, more and more people coming in and saying we're not quite sure because we've read this or we've seen this on Facebook or that, other social media platforms and other kind of channels. And so I felt there was a real need for us to think about this, and particularly those populations, like Atiya said, who may have been underserved previously or may have not built as much trust with the health system. So how can we create new channels and think about developing that trust more? And so over the last 6 or 7 months, I've been more involved with the program nationally, and the rollout has been tremendously successful for many reasons. But one of the key reasons, I think, has been because of the importance of COVID and what people have realized COVID is doing to our friends and families. And I think together, all of us on the panel here have played a really important role in making sure that the right messaging is being spread, but also that we're encouraging people to get the vaccine. But the key strategy that the NHS has been pursuing when it comes to tackling vaccine hesitancy, but in particular thinking about how do we drive the uptake of vaccine in ethnic minority populations, underserved communities, is really using the WHO model of the 3 Cs. Now, some of you may have come across the 3 Cs model, but those that haven't, I think it's important for us to just give the backdrop of what the 3 Cs are and the kind of work we've been doing, because it really helps us contextualize the importance of such a strategy. So the 3 Cs essentially stand for, firstly, convenience is the first C. So that how can the uptake of the vaccine more convenient. That includes things like access, setting up clinics which are closer to people's homes, making sure we have mobile clinics. You may have come across things like the Vaccine Taxi. How do we ensure that it's easy to book a vaccine? And again, a lot of these measures have made it much easier for people to actually go and get the vaccine, because previously you may have had to go to the GP, or you may have gone to the hospital, or places that may have not been that convenient. But through the mass vaccination program, we've made it a lot easier for people to get vaccines. So that's the kind of the first C, which is convenience. The second is confidence, which Dr. Atiya Kamal touched upon, which is to say, how do we build that trust? And again, there have been various mechanisms to do that, but some of the key ones that NHS in particular has focused on in England has been, building stronger relationships with community leaders, faith leaders, working with religious communities, working with trusted professionals such as GPs, nurses, other healthcare professionals, pharmacy chains, and so forth, because there is that trust element that healthcare professionals have, but also religious and community and faith leaders do as well. And we've seen a really, really encouraging uptake because of that, because many faith, community, religious leaders have stepped forward and have really helped build relationships with the NHS and the wider health ecosystem. And I think that's a really exciting proposition for us, because moving forward, we have the COVID vaccine here today, but tomorrow with other vaccines, other healthcare issues that we may have, there's a real opportunity to use that trust and ecosystem that we have. And we still need to keep building on that trust. We still need to keep strengthening that trust, but we are doing, so far, I think, a very good job. And then the third C is complacency. And this C in particular, I think, is of concern at the moment. And the reason why it's of concern is because it tends to impact the younger population more. And a lot of the younger population we've seen, and particularly between the ages of 18 to 35, where the uptake of vaccine is much lower compared to older populations, we're seeing is because many young people feel like the threat and urgency of COVID is not as high as they think, and because of that, they don't want to get the vaccine. And obviously the answer to that is that's not correct, because as Professor Khunti said, we're starting to see more and more young people being admitted into hospital or having the severe symptoms of COVID. And so there's a real important need for us to think about how do we get more and more young people aware of the threat of COVID, the severity of what COVID can do if they get it, and obviously the risk of hospitalization. And that requires us to think about using alternative channels to reach to younger people, so not your kind of mainstream. Many young people don't necessarily have a relationship with their GP. Many younger people don't often go to religious or institutions or faith, have relationships with faith leaders or community leaders. So there are alternative ways to think about. So you may have seen some of the work that's been happening with other social media channels such as TikTok, dating websites, thinking about sports arenas, events, because again, the thing here we have to think about is how do we go to places where young people are going? And again, nightclubs, bars, you might have seen recent press releases around, if you go to Uber or other kind of things that young people are doing these days, that's a way to capture the attention of the young cohorts, because the complacency angle of the C that I talked about is hugely important. So that kind of is the three-pronged approach that the NHS is driving in terms of how do we not only improve vaccine hesitancy, but improve the uptake of the vaccine. And I just wanted to talk about quickly the evaluation part, because in all of this, a big piece of work that's being done now as we speak, and the proposal is being put forward, is to say, how can we then also evaluate which of these community interventions have actually worked? Of course, we've done a lot of great programs. We've got a lot of excellent community programs that have obviously driven, like I said, the uptake of the vaccine. But what we don't know today is how many of them actually work effectively, how many of them are actually producing better outcomes, but how many of those interventions can we then take forward and help to build future programs, whether it's vaccine uptake, but also engaging more with communities. And hopefully that work will get kicked off soon, but that will give us a really good indication of things that can help improve community intervention. So we're excited about that, and we'll see how that plays out. But I'm going to stop there, because I think that hopefully sets the context for our discussion, but just wanted to highlight some of the work that I've been doing at NHS with colleagues in order to help drive the uptake.
Thank you, Harpreet. That was excellent. Thank you. And there's quite a lot of topics that we can come back to, so thank you very much. I'm now going to move on to Lilu. Mrs. Lilu Wheeler, who is a project manager at the East London NHS Foundation Trust. She's had a wide experience of public and patient involvement in not only service development, but also in research, as well as during the pandemic. So over to you, Lilu.
Thanks, Sara. So I suppose my background working with the NIHR as a lay reviewer, a lot of reflections on that. I was grateful to have been on the panel for the BME research proposals, looking at those when COVID hit, and able to see what difference they could make. And I noticed that there were very few applications, if any, from sort of for mental health perspective, for example, for the whole time that I've been involved with NIHR and kind of just participation and involvement in general. I found that some people were not as well represented. So that was something that was kind of ongoing anyway, but here it was absolutely crucial. So although I was pleased to see that there was this money that was been allocated to research, I felt that we were going to be let down. We were setting ourselves up to fail if we didn't have participation then and didn't have people coming forward with that research as people that wanted to get involved. And so I started to have a look at the proportion of people locally that had been taking part in research. And I actually found that a lot of the time data wasn't being collected on ethnicity, which surprised me. And I think one of the directors I spoke with at NIHR said ISARIC, Azaric, who were saying that, we ought to be collecting this data. And so I'm hoping that is sort of, starting to happen now. And I think that is, but, it was very slow at the start. And then I also noticed that although there was a lot of talk about mistrust, the solutions weren't necessarily coming forward. And I was really pleased to see that organisations like South Asian Health Foundation were putting out videos, and everybody else was doing that in a similar sort of way, whether it's TikTok or YouTube or whatever, and just sending that message out of getting that vaccination done, and even WhatsApp messages that people could send around, so that it was kind of countering these fake stories and arguments. I later took part in as a vaccine peer support person as well, and that's been something that's worked quite well in Newham. So people phone up, local people, and they just want to speak to somebody who's had it before and might be a little bit worried, and so this health champions idea is really useful. Sorry, just seeing what else I need to cover. And in terms of the uptake, that had been lower at the start, but I think that has picked up. In terms of community leaders, I think sometimes we very often in organisations just go straight for the community leader and the people that are known. And as Atia had mentioned, they're not always the most trusted people or giving the information that is what we want to deliver. And sometimes women can be left out of those spaces as well. And for me, it's about, if we're going to sort of look at the future proofing, rather than picking out somebody that's already in that space and has that voice, maybe we should be looking at people who could potentially be those champions and those leaders in future, and help and support them and train them up. The other thing that I thought of, and again, I don't necessarily have that research for it, but an idea that I had was that people that don't take part in research, and whether it's research or participation in any other areas, South Asian tend to be a younger group, and younger people aren't always catered for when it comes to sort of participating in things, because they're at 9 to 5, and we don't do evenings and weekends a lot of the time. And although we're sort of getting a bit of online there, I think one of the issues is that some of us have more flexibility in our day to be able to partake in research. So if I to sort of pop out and do that, it wouldn't be an issue. But if you look at people who might be, I don't know, working as like delivery drivers or pickers or something else, for them to say, oh, can I just pop out and take part in some research? It's not really going to happen. And it might be more difficult for them to do that. So one of the things that we could possibly look at in the future is suggesting that local organisations, as part of, I don't know, like a corporate social responsibility or something, enable people to take part in research during the working time, and give them that time to do that. And so, sort of more creative areas that we can have a look at there. I'm going to pause there. Just one thing. So recent stuff around occupancy meters and how there haven't been enough people coming forward for research in those sort of areas. So I think sometimes the conversations stop at, look, we're not being included, but we don't talk about how we then include people. And so I think I'd like to see a bit more of that, of like kind of solution focus and what we do to help people get involved if they want to, because they do. And I think that sometimes they just don't know how, and they're not invited, and the exclusions might not work. And also, an example, I asked my father to take part in the plasma research that was going on, and he tried, and then he was told that he wasn't eligible. It would have been good to have known why for him, because I was there sort of pushing him, and he, you know, he sort of rolled his eyes. Oh yes, you know, they're not going to take me on for whatever reason. They must have had a valid reason, but he didn't know what that was. And so I think we just have to, like, part of those 3 C's, I think could sort of move to this as well, where you actually make it as easy as possible for people to get involved. And then, of course, thank you.
Thank you, Lilu. That was really, there's some really valuable points there, and some interesting points about, I mean, we've always known about the underrepresentation of ethnic minorities in research pre-COVID, and I think really highlighting that in the ethnic uptake of making sure that we've got the ethnic data recording in healthcare notes, etc. That's really important. Thank you for that. And we're going to come back to some of your other comments. But I'm just now going to move to, last but not least, Professor Amitava Banerjee, who is a consultant cardiologist and a professor in clinical data science at UCL. And he's led research influencing several aspects of COVID response, including as well the impact of long COVID. So over to you, Ami.
Many thanks, Sarah, and good evening, everybody. So I wanted to think about the experience I've had personally, then also as a clinician and research as a South Asian, and you know how it's still obviously ongoing. So Kamlesh absolutely sent the first tweet. That's the first time we were thinking about data, but before then, it was on our minds clinically, whether you were in general practice, whether you were in ITU, even as a cardiologist, that the people we were hearing of, whether it was in Birmingham, Leicester, or where I worked clinically in Whitechapel, that there were people who were seeming to be unwell from ethnic minority background, and that was a concern. And I remember when I was walking to work at the Nightingale, and at that time, the risk assessment, which didn't exist at that time, was, Ami, are you sure you're not diabetic or hypertensive? I don't think I am. That was the risk assessment. But there was already a recognition from a couple of colleagues that, you know, by being of ethnic minority origin, I might be at a higher risk. And that, you know, I'd be lying if I said that didn't enter my mind. And then when you were working in intensive care, as I did briefly at the Nightingale, and then in the second wave, doing nursing shifts at the Royal London Hospital, it's very, very much you know, on your mind. You could see that there was a disproportionate effect on people of ethnic minority, and so and the effect that has on an individual plus on a community of the why, you know, whether you're a doctor, a nurse, a physiotherapist, or whether you're a patient or the relative of the patient, you're thinking why that is, because you can see it, you're reading about it. And I think, you know, as Kamlesh says, we're in a different place 18 months into where we were back in March of last year. But there's much more data, there's much more action in terms of trying to build trust, build engagement, but also we've uncovered some issues that are specific to the pandemic, and we've uncovered some issues that were there already. So in terms of issues that are specific to the pandemic, I think Kamlesh, Atiya, Harpreet, and Lily have covered them very, very well indeed. But there's, I think that we now know for future pandemics that we need to be thinking about how we provide information, that one size doesn't fit all, that we need to be constantly thinking about how we build and maintain trust, and also that ethnicity is not first of all, it's measured very variably across different data sets, whether it's Office of National Statistics or ISARIC or in our general hospital data, but also the way it's talked about. And actually, some of the work that we've been doing shows that it's that there are different impacts of ethnicity. So you can think about it in terms of biological factors, you can think of it in terms of behavioral and cultural factors, and you can think of it in terms of more environmental and structural factors. And actually the biological things are what most people think about, but they're the least of those. The most of these factors that are important when you think of the impact of ethnicity, it's, as others were talking about, overcrowding, it's health literacy. One of the areas I've been very interested in is digital literacy and digital access. And so the fact that we have a system which has largely been app-based and digital, whether it's test and trace, whether it's booking of appointments, if ethnic minorities are less accessible in that way, or less likely or less confident to use that, then that's something that we need to think about at the outset. And that's not new to COVID. That's something that we've seen in other disease areas, in cardiovascular disease and in diabetes as well. So this, going forward, we need to take into account, and maybe rather than having a digital for all, having a digital first, and having provision for people who can't do things digitally is important. And my final reflection would be that along the same lines, that I think we've both philosophically and research-wise come to a point where we need to think about what is ethnicity and the research in ethnicity for. Are we recording it properly? Are we making is the research going to give us the kind of answers that can produce solutions? Because unless you think of the whole thing, take a label like South Asian, the amount of heterogeneity within that is enormous. And we've seen when we looked at the risk in the Bangladeshi Pakistani community, that seemed to be higher than in other ethnic minority communities within the South Asian diaspora, and that's largely due to the other factors. So we need to think about beyond the pandemic, where we go and how we act on ethnicity in health. I'll stop there.
Thank you so much, Ami. Some really valuable points again, and some of my reflections as well, being frontline key worker and being South Asian. So I've got lots of questions, but I just want to remind the audience, if you've got any questions or comments, please drop them in the chat box and we'll try and pick up as many as possible. I think one of the things that sort of came out as a theme was trust. The issue for trust from the ethnic minority communities. And I was, with not only is COVID affecting South Asians more often, but also with the vaccine hesitancy. And I thought maybe we could start off the discussion with Atia. If you could talk about how would you overcome this issue with trust?
Yeah, it's so important. It really underpins everything at every stage of the pandemic and moving forward. So if we think of what some of the reasons are for mistrust, there's difficult experiences, actual or perceived experiences of discrimination, and it's stigmatizing communications which may not have intentionally been designed that way, but have sort of ended up, during the pandemic at least, sort of highlighting certain communities as being problematic, or labelled as increased risk, and then due to that, poor choices. Whereas we know, as Kamlesh has mentioned, there are many structural factors and inequalities that have contributed to some of the poorer health outcomes that we've seen. And so with all of that going on, in terms of the reasons for mistrust, what we need is to have an open dialogue. We need to have this two-way conversation where communities have the space to be heard. They can, their concerns are acknowledged and it's non-judgmental. So I think that's the first thing, is let's get these lines of communication open. And then it's about moving towards these sort of shared goals. And, we all want the pandemic to end. Everybody, there is a shared goal here. It's just, having these targeted and tailored approaches isn't about highlighting certain communities again as problematic. It's about just making the information more accessible, but keeping in mind that the goals are the same. The risk, everybody is at risk. Everybody should be vaccinated. It's not that one community is any more or less problematic. So it becomes an issue of equity, I guess. And then just sort of my final thoughts on this are to bring people to the decision-making table as well. When communities feel that they're not being heard, decisions are being made for them, it's very top-down, then it might not meet the needs of the community, or again, they might not trust the reasons underpinning those decisions. And so it's about bringing people from within the community to be part of those decision making processes. And the local and the community champion scheme has actually shown that can be done, and it can be done well. Have this decentralized structure in place, have local authorities, formal authorities, making provision so that they're sort of working creatively and in a slightly different way as well. So the resourcing is there, but communities have got a little bit more control in terms of some of the activities or what the communications might be, or the places within the community where they think the support is required more. So those are just some initial thoughts on that.
Thank you. That's really useful. I also wonder about not just the lay people, the communities, but also frontline health workers and the trust there. And I was wondering if any of you had any comments on that or experience of that, and maybe Harpreet or Ami or Kamlesh, or Lidu, or any of you. Okay, Kamlesh.
I think the trust issues that Athia's conveyed are exactly the same in healthcare workers as well. And when you look at the data, for example, vaccination rates, it's exactly the same as at population level. It's the Black community having lower vaccination rates, and then the South Asians and the whites the highest. And all of this, the trust, I think, especially is so ingrained within the Black community, because the Tuskegee syphilis study that was done in the mid-20th century in the US, and people still remember that. And I think the other thing, if you look at vaccine hesitancy, it's following exactly the same at population level. Even in, you think healthcare professionals would be more likely to take up the vaccine, but we're still seeing that, not as much, but still there. Same pattern is reflected there as well. And again, some of this is because the data, we're talking about research, the data on what proportion of people were in those studies that have been done on vaccine, in the initial phase 3 studies, they don't report data by ethnicity. So a lot of people think, well, it hasn't been tested, or they haven't reported ethnicity data. And it's all, it's all quite interrelated. And we've, and a number of people on this group have called for more data to be explicitly detailed by ethnicity, because if people have that data by ethnicity, they'd feel more comfortable about it.
Ami, did you have a point that you wanted to bring in at this?
No, just the very first thing Kamlesh said, that we're health professionals are just people and not exceptional, and so the same, exactly right, that I was working on ITU with a colleague who had similar concerns about vaccination, and which needed to be talked through and addressed like anybody else. Just the fact that they were working in that context didn't necessarily mean that they weren't thinking through those same things or didn't have the same information to try and find their way through. So it's absolutely true.
Thank you. Harpreet, I just wanted to come back to you about vaccine hesitancy. And I know anecdotally, I don't know, in my area, I found that actually the older populations were actually getting their vaccines. And I wonder whether this is, I don't know if we've got any data on ethnic minorities vaccination, and particularly in the younger groups, and what we can do to help build the trust and bring them forward to have the vaccine.
Yeah, no, absolutely. And I think the point, I raised earlier when I was talking about the complacency part of C, which was to suggest that, a lot of healthcare professionals may not have relationships with younger people. A lot of young people are not necessarily going to their GPs or using healthcare facilities because, hopefully a lot of them are fit and well on the whole. Whereas, those that are slightly older, may have chronic diseases or others, they have a trusted long-term relationship with their GP. So, they come forward a lot more. And so the question arises then, how do we help build that trusted relationship? And the challenge we have is also that many of the younger populations are, growing up on a generation of using tools and resources that are, different to a slightly older population. So, older populations would watch, again, if I'm using my own personal experiences, Indian TVs or talking to their friends and families when they go to events, whereas the younger populations are being exposed to lots of different resources and sources on online channels, social media platforms. And the question is, how can we ensure that whatever they read is of the right, credible source? And it's very difficult to do. So many of them come with already formed views because they're saying one thing, someone else saying another, and many of them feel like they are always quite well informed, but it might be to the contrary. So again, the question is, how do we bring them to a forum where we can have these open conversations and discussions and help them understand the science, but also, the importance of vaccine. But the challenge is also getting them to the first place versus actually then having these conversations. And I think that's the ongoing thing we have to think about, is how can we build that relationship, which takes time. And it's a wider phenomenon at the moment where I feel that the younger generation are just not trusting institutions in general, and that's not just playing out in healthcare, but just across the whole spectrum. And I think that is obviously having an inevitable spillover into healthcare, but that's a wider issue that needs to be looked into, is that how can we help support younger generations in general, and obviously with COVID, healthcare is having an impact on that.
Thank you, Harpreet. So it's really about also thinking outside the block, and you mentioned about the dating apps and the other venues that young people may be attending. I just also wanted to actually go back to Lilu and ask her about her experiences with working in the communities with ethnic minority populations, as well as sort of building their trust and bringing them into research. Is there much training going in for both the researchers but also the lay people to retain them, to get them into the research and to retain them?
I suppose in short, no. I guess research isn't something that people in my community, at least, I guess, as Amit has alluded to, that the South Asian population is quite diverse, but if we talk about sort of lower SES, socioeconomic backgrounds and people that are probably most at risk of the adverse effects of COVID, for example, they're less likely to know about research, what's available out there, what happens with it, how the data is used, or any of that. Anecdotal evidence here, but found that people don't always get invited either, and told about it, because it's kind of thought of as, oh, they're not really going to know about it or bother, or, you know, and kind of assumptions. Even when I've sort of spoken to clinicians myself, sometimes I find when we're talking about getting somebody involved, there are words, language that will get used sometimes, like, oh, we'll use so-and-so because they articulate really well. What do we mean by that? You know, and yeah, I think sometimes that there's not even the invite or the training. I mean, I found out about NIHR, for example, from a friend that I had worked in Warwick, who was already in research, and I was at the time unemployed, had just had a baby, and just, you know, had a bit of time on my hands, and she said, oh, I think you'll quite enjoy this, and I that's the process I went through, and actually most people that were on the panel with me were people who had been introduced through friends, family, partners. I am a bit of an anomaly there, but you know, I think to get more people like me, I think we need to go into the communities rather than getting people to come to the hospitals and universities and everything. You know, go to where people already know. So, you know, they're dropping off their kid, for example. You've got the school hall. Are there places that you can sort of, you know, tick off people and tell them about research and say, oh, if you got, you know, half an hour after you've dropped off the children, and we'll tell you about what we're doing here. Just, you know, different ways of engaging people, I think, than what we've done previously. And also videos help as well, more than translation sometimes. For example, I'm involved in a couple of research projects myself as a participant. There's a Covidence, and alongside that the vitamin D, and my were doing something. And I remember getting this little pack, and I had, you know, I did think, how am I going to be giving blood? Are they, you know, how are they doing this? And they had this little pipette thing, and, you know, to sort of, yeah, you had to kind of put your own finger and do it, and yeah, it was easy enough once you got used to it, but we're not used to doing that. And I suppose if we're teaching public to lay people to sort of, you know, stick something up their nose and kind of test for COVID, then surely we can sort of do the rest of the stuff and bring people with us. So I think it's all possible, and you know, things like phones, smartphones, most people have that, even if they're not IT literate, they might use some of that. So just how it's displayed on your phone would be quite useful as well. If there's questionnaires, just making sure that people can complete them on a phone and submit that.
Thank you, Lulu. I think that's a really good point about, it's not just about the language in which we provide information in. So thinking about translated written information, but it's also the format in which we give it. We know that South Asians like Bollywood movies and dramas. So, you know, we should be using that medium of film and drama to recruit people. And I know that the NIHR did produce little short videos in that context. So yeah, that's a really good point. It's about thinking out of the box. So there's actually so much to cover, and we've been so lucky, but I just want to come back to long COVID, if that's all right, because I feel that we have this, you know, the South, well, all of us, but the South Asian community is aware of going into hospital, being admitted, and the risks of death, but we, you know, don't talk that much about long COVID. And I was wondering if I could bring in Ami at this point, because I know you've done some research on long COVID. Is there any research on long COVID in South Asians? What about the clinics, etc.?
Thank you, Sarah. So it's a really important point, because we've talked about the disproportionate effect directly in terms of the hospitalisation. Also, the so-called indirect effect, so cancelled procedures, cancelled outpatient appointments. They're in whether it's cancer care or cardiovascular care, people have talked about ethnic inequalities and those things from before COVID. And so in long COVID, there is a lot of interest. Preliminary data from for example, the clinic that my colleague Melissa Heitman runs in London shows that actually the patients attending are less likely to be ethnic minority and less likely to be from deprived backgrounds. And so that's important to unpick that, whether that is part of the risk factors of the disease, or whether it's about who is being referred to the services, who's able to access the services. And so we have to be really, really careful how we interpret those data until we see it from around the country, from different areas, and how we make sure that our services are equitable.
Harpreet first and then Kamlesh.
Yeah, I think thanks, Sarah. Just to add to Ami's point, I think that the other thing we have to think about in all this is, are the South Asian population also aware of what long COVID is, and are they talking about it enough? Because a lot of them may not be aware that such thing exists, because the press or the media or whatever it might be, the channels that they use, we may not be talking about it enough in that community, and so many of them may not even know that such a thing exists. So I think there's also that dynamic that needs to play out here.
I was just going to add, I think some form of work, and Lilu and Atiyah will be experts at this, working with the community, because I agree. I don't think that term long COVID, what does it mean? It's not out there yet. So I think a lot needs to be done. The work Ami and I were involved with, the ONS, which was published a few months ago, showed that ethnic minority groups possibly had higher rates of long COVID, but that was really early data, and really glad that there's been 6 or so epidemiological studies that have been funded, AMI's being one of them, that are looking at long COVID, and all of them, I feel, will be looking by ethnicity as well. So we will have quite a lot of data coming out soon.
Atiyah, do you want to come in with that? Yeah, just to say that I think what we've been talking about in terms of the journey of the pandemic and the South Asian community's experiences rest on a series of principles and mechanisms and good practice. And I think all of that translates to the issue of long COVID. As you say, is that understanding there? Are the communications reaching the communities in an accessible way? Simple translations aren't enough. So if we were to just translate long COVID into Hindi or Punjabi or Urdu, does that mean anything? And it's about making that accessible. And I think there are lessons to be learned still, even as we enter the next phase of the pandemic. So there's more work to be done.
Leela, would you like to add anything to that?
Thank you. Yeah. Just to say, I think people, it's a bit like access to mental health. So if people are already in poor health anyway, so they might have, diabetes or asthma or whatever else, when they have, that is part of what they already have, or, it's called long COVID, and so may not seek help in the same way.
Thank you. Okay, so we're now coming very to the end. So any last 30-second comments from each of you? So Ami, take-home message.
So we've never had as much data as we do now, and we're getting more. And there are good news stories. We're in a better place than we were 18 months ago. I think what Atiyah just said is really important, that we think of like, what are we going to do in the next pandemic? But long COVID and COVID is teaching us things about how to treat chronic diseases, how to reach other communities, how to bridge primary care, secondary care. So we need to think beyond infectious disease and pandemics. Thank you.
Kamlesh, last comment.
Yeah, huge disparities still. The age distribution of people admitted to intensive care has come down from 65 to around 40 to 50. But 35% of people in intensive care units are still non-white. So there is a disproportionate impact. We need to get these individuals vaccinated.
Harpreet.
Yeah, just a quick message, and I said this yesterday as well. If you are called for the vaccine, do come forward. Make sure you get it. If you're part of a young cohort, make sure, if you're unsure, speak to your GP or healthcare professional. All parents watching out there, make sure you get your kids vaccinated, and all youngsters watching out there, make sure you get vaccinated and get all your friends vaccinated, because that's going to be a key aspect of this. Thank you.
Last comment, Atia, I think Lilu, and then we say thank you to everyone.
Yeah, so my final comments are, let's work with communities as partners, and while we have had to be reactive, at many stages of the pandemic, let's move towards becoming proactive as a routine, as routine practice and ways of working.
You?
This gives us a real good opportunity actually to get people interested and involved. People are interested, but get them involved in research and participating in trying to get people vaccinated and service delivery.
So drawing this now to a close, I just want to big thank you to my fantastic panelists, to Bonita Kane and the South Asian Heritage Month, and to the South Asian Health Foundation, and of course the audience for listening. Thank you so much. Have a good evening, everyone.